So good morning from me. We'll continue talking about Hindfoot dislocation, and it's really a very interesting topic, a topic that, because they're so uncommon, usually a single surgeon cannot accumulate enough experience in their career span. And we're very lucky to have accumulated a great assembly of surgeons that are both very experienced and they work in referral centers. So apart from that, on top of that, they're all devoted teachers, and they have trained great numbers of surgeons themselves. So we will have in our panel Serafeim Tsitsilonis, and he's the Senior Managing Consultant, Hospital of Schepers University in Berlin. Good morning, Serafeim. All good with your microphone? Good. And followed by Stefan Rammelt. He's a professor at Dresden University. We are also have the privilege of having Professor Ahmed Kholeif from the Cairo University. And of course, last but not least, Tim Schepers, a great trauma surgeon, very prolific in writing very interesting and useful papers. So we will start with Serafeim presenting on ankle dislocation. The floor is yours.
Panos, I think he is still struggling with his sound, so you may want to move to the next person first.
Great. So I think that we will have Stefan presenting on extruded chalices. I think your slide is 2 to 5, and we'll switch to Serafeim later on.
All right. Good morning, everybody from Dresden, Germany. Do you see the presentation now?
Yes.
Yes. All right. So that's the little town I come from. And I will speak about a very rare injury, the extruded talus. So what is that? When we look at the peritalar dislocations, we just heard about Schepers dislocations in the previous session, which is a dislocation around the mid-tarsal joint. The total talar dislocation is a dislocation of a talus of all its 3 joints. That means the tibio-talar joint, the subtalar joint, and the talar-navicular joint, which makes this distinct from subtalar dislocations that will be dealt with later, which is just the talar-navicular and the subtalar joint, and the tibio-talar dislocation, which also is a very rare animal. That means a dislocation at the ankle joint. So these are very rare animals, and we are in the promille region when speaking about incidences. It was probably first mentioned by a French guy named Broca, who called this an enucleation, which is also a very symbolic thing. The first series that was out there in the literature was from the United States, dating back in Kelly, and they had devastating results. I think they had 9 patients. Most of them were open injuries, and they ended all up in a stragglectomy, fusion, or even amputation. And as you can see, both the open and the closed injuries are surgical emergencies. It goes without saying for open injuries, but also for the closed injuries, a total dislocation of the talus puts so much pressure on the skin from the inside that if you don't act quickly, there will be skin necrosis and further problems down the line. So I haven't seen them for quite a while, and my former teacher Hans Zwipp told me you probably see them once or twice in your career. But now we have that new device in Dresden for entertainment. It's called Superfly, and it's a big trampoline area. And from there we get some very interesting injuries we otherwise would not see when people jump up to great heights and then do not hit the trampoline, but the margin of it. And then these kind of injuries will result. So here we see a closed total talar dislocation. The talus is spat out to the front. It's twisted completely, and you can see the tenting of the skin right over that area. So this is an emergent procedure. The patient was taken to the OR. An X-fix was put on, which could be connected to this traction device, and then it was fairly easy to get the talus in from the front. In my opinion, it's easier than getting the talar body from the back in a talus fracture dislocation in a Hawkins type 3 fracture. The external fixator was kept on for soft tissue consolidation, and this is the post-reduction CT, which should always be done because this is a high energy injury and there might be some fractures around. Here we can see a small shell-like fragment from the medial talar head that was spat out and was lying just behind the medial malleolus then after reduction, and we opted to just resect it. And then on intraoperative testing, the ankle was stable, so the external fixator was discontinued. And this is the patient 10 weeks later. He's walking full weight bearing and has quite a reasonable movement. Here's another case. A 50-year-old patient fell from a ladder, has an additional Lisfranc injury. Again, you see the talus is spat out to the front, and in this case, also dislocated far medially. And if you look at this, you can see laterally, sorry. If you see, this is a CT scan that has been taken before reduction because people were anxious about further fractures. You see several shell-like fractures, both at the talar head and maybe at the posterior process. Maybe this is an ostrigonum that has now loosened. And this is the 3D scan of it. So you see small fragments all around that dislocated talus. This was the treatment at the night of admission, open reduction by an anteromedial approach, maybe quite big screws for that small fragments, but somehow the people wanted to get hold of it. And in the same session, it was decided to transfix the subtalar joint and the talar-navicular joint with K-wires, and the Lisfranc injury was addressed in the same session via a dorsolateral approach because it was mainly a lateral Lisfranc injury, as you can see here. The FixX was kept on for 10 days because it was felt to be rather unstable and also quite tense soft tissues. They all healed, settled down. There was no compartment syndrome in this patient. And this is him 5 months later. Everything healed. And most importantly, there's no avascular necrosis of the talus, which is, of course, always a concern if it's completely detached from everything else. And this patient came 11 years later to the internal medicine clinic into neurosurgery for a tumor. She didn't have pain he didn't have pain in the left foot and declined any further radiographs. So unfortunately, I don't have a long-term follow-up. There might be some arthritis, but we don't know. At least it was clinically not relevant. Here's a case of an open talar dislocation that was sent to me by a colleague. And interestingly, this was a patient with insulin-dependent diabetes and some neurological problems. I don't have follow-up on this case because that's mine, but this went on to an early TTC fusion, and I think you have to be generous with that in diabetic patients. Otherwise, the talus might probably dissolve by itself. Here again, a case that that was sent to me by a colleague, and this is probably on the verge of being an open talar dislocation. You see how the skin is tense and maybe like a puncture wound there on the lateral side. On CT scan, you see that there is a posterior process fracture. So these peripheral fractures are quite often. Here you see the anterolateral approach, and you look at the tilted talus from below, and you can see in the subtalar joint facet, you can see that marginal fracture. So it was reduced, and then in the second step, the posterior process fracture was fixed via medial osteotomy in this case. And here's one of our patients that was brought in. So she was somehow doing cherry picking, went on a 3 meters ladder and fell from there, had an additional lumbar spine fracture and this open talar extrusion. These are the initial x-rays, and we can see the talus is extruded medially and the whole foot goes laterally then, and in this case the calcaneus knocks on the distal fibula and produces a direct fracture there. So that was the night of admission. Before doing a CT scan, the talus was put back, was fixed in the subtalar and talionavicular joint. The ankle joint was deemed stable. And this is the post-reduction CT scan. You can see the direct blow to the fibula from the calcaneus, like in a calcaneal fracture dislocation. And you can, in addition, see that avulsion fracture at the anterior process. So we went back. This was the fibular fracture, the direct blow. We went there across the peroneal tendons. This is the anterior process fracture of the calcaneus. You both can access them with an anterolateral approach. And this is the fixation of the fibula and the calcaneus. And finally, the peroneals went back where they belonged. And these are the post-reduction radiographs. 6 weeks later, the K-wires came out. And this is the 4 months follow-up. Some residual pain beneath the fibula, but otherwise doing fine. And again, no signs at that stage of necrosis. And the last case, 80-year-old female, multiple injury after motor vehicle accident. She was treated in another institution that way. So they were anxious to keep everything and get everything back together. But of course, that long wire and pin also hurts the articular surfaces. So I'm not a big fan of that. That was the big pin. We were taken out like a chance screw. And we went in from posteromedial. Here you can see the neurovascular bundle, the FHL tendon, and tried to reconstruct the posterior process and posterior talar body as good as possible. We thought we did quite a nice job, but she came 1 year later, not for ankle fusion, but she was having renal failure, went to the ICU. So she didn't care much about the foot, but that, of course, is, I think, avascular necrosis with partial breakdown collapse of the talus. So interestingly, the 4 cases that we have treated, this was the only AVN. And when looking at the literature, this is a meta-analysis from 2015, 86 cases. Most of them were open, and more than 1/3 had additional fractures, most of them around the talus. The talus was preserved and replanted in most of the cases, and the results were 1/3 good, 1/3 fair, 1/3 poor. And interestingly, the overall rate of avascular necrosis was just 26%, and it was not much different between fracture dislocations and pure dislocations. Even less patients with symptomatic osteoarthritis, 16%, and 10% infection, which is also interesting in a predominantly open injury. So the authors concluded that replantation should be the first line of treatment. And to quote my former professor, Hans Zwipp again, he told me, even if the dog brings on the talus in his mouth, I would wash it and put it back in, because there's no such thing like a talus. Just briefly looking at the results in them, they echo the same thing. Most of them have no collapse after bringing the talus back in. Some do, but the rate of avascular necrosis with collapse is rather low. And of course, you have to have plan B if the talus is gone, if just nobody brings it back. And if you have complete avascular necrosis with collapse, and this would be the topic for another talk. So to conclude with, it's an extremely rare injury. It's high energy. Typically, the talus is spread out anteriorly and then goes laterally or medially, and the rest of the foot goes the other side. It's very frequently associated with peripheral taral fracture and peritalar fracture at the fibula calcaneus. So get a post-reduction CT scan after emergent surgery. And the concerns are infection, ABN, and arthritis. And luckily, the rates of those are not as high as one would think. So thank you very much for your kind attention.
Thank you very much, Stefan. These were the most extruded taluses I have ever seen and probably will see. Guys in the audience, please feel free to ask questions. You can use the chat box and place your questions. And if there is time in the end, we will address them all. Serafeim, you are next, and you will be presenting on ankle dislocations. Thank you.
So hello everybody from my side too. Sorry for the technical problems, a little bit of stress Saturday morning. So I was asked to talk about the ankle dislocation, and well, the ankle dislocation has a lot to do also with the anatomy of the ankle. The ankle is more than a hinge joint. It has also the 3D movement of the fibula, and the axis is not horizontal, as we know. And of course, the form of the talus itself plays also a very important role, because you have a ventral side which is broader than the dorsal one, and the lateral shoulder is broader and steeper than the medial one. And why is this important? Because it dictates, together with the external forces, more or less the trauma mechanism and the way or the direction the joint goes during such an injury, as you can see here, because you have abduction forces, you have rotational forces, and this is also important for the treatment, as we will see afterwards. So if you see such an ankle, of course, don't wait for the X-ray. Please don't. Just reduce the fracture immediately, either on the side or the emergency room, because you want to prevent any fragment pressure from inside. You want to protect the neurovascular structures, and of course, you want to reduce the pain for your patients. Yeah? So if you see those pictures, well, these are something where you have to shoot, more or less. Yeah? But sometimes the close reduction is not enough, and then you have to go for the external fixation. Mostly in cases where you have a high instability either of the bone or the ligaments or both of them, where you have severe soft tissue injuries or open fractures, and of course in polytrauma cases. The typical external fixator, only in the tibia and in the metatarsal ones, bones doesn't work. Sometimes you need more stability, then you have to go for the calcaneus pin. For us, the indication is system instability after the first external fixator, and of course if you have extreme unstable fractures. And just a tip here, where we want or where we prefer to put our pin is a little bit more plantar to the calcaneus, especially in osteoporotic patients, where you have a little bit more bone there, and of course you can avoid the neurovascular structures, as you can see in the down right picture. How do you classify those fractures? Well, there is not an extra classification for the ankle dislocations. And why is that so? Because let's say it's the evolution of a normal fracture if you have even more forces there. Yeah, so we have, of course, the AO classification, which is no one. But what I find really nice for those fractures is the Langen-Hansen classification, because you can understand also the mechanisms there. So you have 4 types of fracture mechanisms there: supination and adduction, pronation and adduction, supination and external rotation or eversion, and pronation external rotation, as you can see here. And there are several different stages in every one of those. And don't forget, it's not only the ankle, you also have the syndesmosis, and it's a really important thing. So every fracture, if even you don't see a fracture of the fibula there, like that, you need to test for the syndesmosis. You need to test at some point whether you need a positioning screw or not. And of course, there is a clear suggestion for fractures like the pronation eversion fractures, a special form of Maisonneuve fracture. But of course, you have to examine more or less every fracture like that. And of course, if you have even the slightest instability, you have to go for the stabilization there. And the gold standard is still the positioning screw, the 3-cortical positioning screw. I would like to go a little bit in detail in all those 4 types of fractures that we have. The supination adduction fracture, as you can see, you have stadium 1 or 2, according to Lange-Hansen classification. And you can see here, well, the stadium 1 is the normal Weber-A fracture. But if you have this stadium 2, where you have also the vertical fracture of the medial malleolus, you can very easily go to fracture dislocation there. And of course, you also have the pronation abduction fractures, as you can see here, when you can also have the horizontal fracture of the medial malleolus. You have the impression of the medial tibial plateau, and you have a bending wedge or a multifragmentary fibula. And why is that important? Well, it's important because it dictates more or less the type of treatment that you have. And also you can have complete dislocation in that area. But these are fractures that when you analyze them, then you can treat them quite adequately in such a manner, and then they have a very good outcome at the end of the day. And of course, you have always to check whether you have a syndesmosis instability in that area. The third type of fracture that we discuss about is the supination inversion fracture. As you can see here, and with inversion, I mean the external rotation. You also have here those 4 stadiums, as you can see, stages with the oblique spiral fracture of the fibula. And you can also see here that at some point, as you go more and more with more energy, you can also have fractures of the medial malleolus, and then it can also lead to complete dislocation in that area. In the case of a supination inversion fracture, as you said, we can have stage 2, which is quite stable here. But if you have more energy there, even more energy, you have a complete unstable fracture. And of course, it also can lead to dislocation. And why do I say that every time? Because as you can see, there are normal fractures with more energy. So if you understand the mechanism of injury, you can address the pathology. And of course, the last one, the pronation inversion fracture, which is a transverse fracture of the medial malleolus and high oblique fracture of the fibula with a syndesmosis injury. So you can have more or less, you can understand the pathology there and address also different types of fractures that you have there, and also put, of course, your positioning screw, as you can see here. But if you put a positioning screw, of course, you already need to understand what's going on. The question of the questions over the last years, Volkmann fragment, do I need to fix it? There are those old rules, whether you have more or less than 25% of the joint. Well, this is not true anymore. We know that if you have involvement with the joint surface, depending, of course, a little bit on the size, the displacement, and the impression, if you have reduction obstacles, and of course, check the Rammelt classification. It really helps you to understand what's going on there. Then maybe you have to address it also directly. And how do you address it? Well, it depends, of course, on the type of pathology that you have there. You can use every type of approach that you have there, either posterolateral, posteromedial, the medial, or the lateral one, and you have to be a little bit acquainted with those types of approaches there in order to achieve the best possible result. And afterwards, you need, of course, your reduction control, known criteria. And don't forget, not only the X-ray, but you also need a CT control, either intraoperatively or postoperatively, because you have to be sure that you have a very good positioning screw and you have a very good reduction of syndesmosis. I will say a couple of clinical cases. This is a 40-year-old lady. She fell off the stairs. She had this trimalleolar ankle dislocation fracture, and she had at the beginning an external fixator due to the fact that it was the soft tissues were a little bit compromised. And after the consolidation of the soft tissues, we went ahead and we did a direct dorsal fixation of the Faulkner fragment and of course of the fibula with this anti-gliding plate. And in that case, when you have such a good stability also from the Faulkner, then you don't need a positioning screw, of course, because you know you have a very good stability there. Other cases where we also had an ankle dislocation, here you can see that you have also the C fracture here with the high fibula, more or less, where you will definitely have also a problem with the syndesmosis, but you also see here that you have a lot of intra-articular problems there. This is something that maybe you could also combine with an arthroscopy, because then you can also address the osteochondral lesions that there are quite often in such fracture dislocations. It can go up to 80% of those fractures. And of course, you have to treat also the syndesmosis here, and then you can do an intraoperative check of whether everything is fine or not. This was also quite interesting case. It was a 30-year-old boy, male. He is actually a professional athlete, and he came also with this dislocation. Well, you have to go directly here. This is a special case. Those those pediatric fractures, you cannot really classify them according to the Laugen-Hansen classification. So you have to be a little bit more aware in that case and analyze the injury. And then you have to go open the lateral side. We also had to address the syndesmosis, and we had such a case here. Yeah. And the final case that I had, it was an ankle fracture dislocation. It was also Laugen-Hansen grade 3. They put a cast in it. In the other hospital, it was more than obvious that it would not work with just close reduction and a cast immobilization. We had to go for the external fixator. And afterwards, as you can see, you need your CT pre and post-operatively in order to be able to assess and reduce the fragments that you have there and be able to achieve the best possible outcome. Well, thank you very much. That was from my side.
Thank you very much, Serafeim. A quick question from the audience. If we have an ankle fracture dislocation, do you recommend immediate reduction before the x-rays, or will you wait after you see the injury? So do you attempt a reduction in A&E, or you wait for the injury, or you wait for the x-rays?
If you have an extreme fracture dislocation where you have a compromisation of the soft tissues, you have to react immediately. You don't need to wait for the x-rays. This is what I meant also at the beginning. The best thing would be not to have x-rays with dislocated ankles, because it is a clinical diagnosis at that point. You see that.
Yes, I think we all agree on that. So the next speaker would be Professor Kholeif, and he will be presenting on Professor Kholeif. He will be presenting on subtalar dislocations. And Ahmed, the way people drive in Cairo, I think you will have a lot of experience with this.
You are absolutely right. We have cars, we have motorcycles, we have rickshaw, and, and I think, orthopedic trauma surgeons are making good fortune in my country, but but not me, actually. Okay, greetings from Cairo. Can you all see my presentation? Hello? Can you see my presentation?
Yes, yes.
Okay. So we are going down now from the ankle dislocation to a bit uncommon subtalar topic, which is subtalar dislocation. Congratulations from Cairo. Myself is Ahmed Kholeif. I'm a professor of orthopedics in Cairo University, and I'm the chief of the foot and ankle unit in Cairo University. In subtalar dislocation, we're going to give you some updates about the directions, types, and subtalar dislocation. There might be associated injuries, open versus closed dislocation, reduction maneuvers, rehabilitation after that, and the final outcome. This is actually a recent topic about subtalar dislocation. It's a narrative review. Most recent literature published 2022, done subtalar dislocation, studied about 47 articles published throughout the past 30 years on 389 cases. So you see, over 30 years, 389 cases. So it's a bit not very common, but when it comes, you need to know it and to get very acquainted with it. First, we start with the classification, the talar dislocation, and we have subtalar talonavicular dislocation, or peritalar, medial, lateral, and anterior-posterior dislocation.
Ahmed, you have to advance your slides.
I'm advancing it.
I'm press next. Yes.
I'm pushing next. Can you see me? It's on my screen. It's being advanced. You still see my home screen or what?
We just see the first slide.
Very strange.
Did you take control? Did you press take control, top left?
Yes,
So
yes, I press. Take control here, take control the presentation. Yes, here we are.
And then you have also to push
audience. Yes.
Push audience, yes. Yeah. Now we
Can
can
you see it
that.
now?
Yes.
Okay.
Now it's working.
Okay. Sorry for that. Okay. I kept talking. Okay, so this is the article about subtalar dislocation. I hope you can see the topics of it. And we are talking about mainly anterior, posterior, medial, and lateral subtalar dislocation. So this is talar dislocation, anterior, posterior, subtalar talonavicular ankle dislocation, and the total dislocations that has been given by Stefan Rammelt. Medial subtalar dislocation is 55% of all cases. So you can see the medial subtalar dislocation is the commonest one, mostly associated with low energy, like someone going up and landing on his foot with forced inversion and plantar flexion, and we even call it acquired flat foot. Sorry for that. It's low energy mechanism, forced inversion, and plantar flexion mechanism, and as you can see in this video. And this is the thing that you can see. It looks like an acquired clubfoot deformity with the talar hip. Most probably can be feel on the lateral aspect of the foot. So you can even see it, or it can be open if you can see it this way. And this is the way it looks like. The talus is dislocated. Foot is dislocated medially, and the talar head is pointing out laterally. And if you have a CT, if you have time, because this is an emergency situation, and you need to get it done and prepared. Yes. Lateral subtalar dislocation, this is 15%. The lateral one is the foot goes laterally. It's 15%. So you can see 85% medially, 15% lateral. Anterior posterior is very uncommon, even it's not being counted. And this one is commonly associated with high energy trauma, with more forced eversion, with associated fractures with the ankle, midfoot, and the metatarsal. And we can call it the acquired flat foot. So you can see we are having a sequence between a cavovarus foot and acquired flat foot, with the talar head now being felt medially. And this is a situation you can see with the foot dislocated laterally this way, and you can see the talar head is popping up on the medial side, as you can see here. Posterior subtalar dislocation is a bit uncommon, and you can see it here where the calcaneus goes backwards and the talus is there, very uncommonly seen. And this is the anterior subtalar dislocation. These are very uncommon categories that can be rarely seen. The dislocation, the closed reduction, step one, how to do it, because this is the one we need really all to know, because when you have the patient in the emergency, the foot is really at risk. So you need really to put it back to its place as you can. So you flex the knee to relax the gastrocnemius, plantar flex the knee, do traction on the foot and the heel with counter traction on the leg, and then you increase the deformity to unlock the dislocation. So if you have like a medial, you can just push the foot on the side where it is dislocation in, just to as deflection or abduction, and then you force it back to its place with the traction to reverse the deformity, as you can see here. After you close the reduction, you need to check for the congruency of the reduction, check for the stability. You can even put a pin in the subtalar joint if unstable. So you can just a transfixing pin and immobilize the patient in a splint. And after closed reduction, a post-reduction CT is mandatory for residual subluxation, especially the subtalar joint. You might have some occult fractures, so don't be just satisfied with the X-ray, because there are so many hidden injuries that can be done. And of course, you need a post-reduction CT if you have an irreducible reduction. In some situation, you can have this irreducible reduction. For the medial subtalar dislocations, acquired club foot with forced inversion of the foot in the plantar flexed position with stress to the lateral malleolar ligaments apparatus causing rupture of the talocalcaneal talonavicular ligament. The talus remains correctly positioned, strangely enough, in the tibio-tarsal joint, while the subtalar dislocation, okay, so you can see here in the X-ray, the talus lies nicely in its position, and the whole foot is going this. And I call this the patient is walking with the foot beside him. So he's walking actually on the talus, and we see this sometimes in Charcot arthropathy. You can see the foot lying beside the leg. So lateral subtalar dislocation is called acquired flat foot, requires a very high energy trauma, was associated with fracture, soft tissue injury, and open dislocation. States that it occurs nearly in 40% of the cases, and this is more difficult to reduce than the medial injury. As I mentioned, the associated injury, you can have a pure ligamentous dislocation with excellent prognosis after pro-reduction, but sometimes you can have lateral process of talus injured, sustentaculum trifracture, and unfortunately, talar avascular necrosis is reported up to 50% of patients after complicated subtalar dislocation. Closed versus open reduction, this shows that lateral dislocation are twice more likely to be to open a dislocation than the medial side. So having, because you can see it's very easily the talus to rupture through this injury. And reduction maneuver, nearly half of the cases in lateral dislocation require open reduction, in contrast to quarter of the cases have the medial dislocation. Medial dislocation are more easily going for open reduction. So what about the closed reduction? The outcome failure is nearly 1/3 of the case of dislocation. So be always prepared for having an open reduction. Proceed to open reduction in lateral dislocation for nearly 50% of cases, and for the medial cases in nearly 25% of cases. But always be prepared for having this reduction. Reduction of the subtalar dislocation is often prevented by inclusion of soft tissue or bone fragments. For the medial subtalar dislocation, you can have intervention of the extensor retinaculum, extensor hallucis brevis, or extensor digitorum brevis. For the lateral subtalar dislocation, of course, the posterior tibial tendon is the most common structure to be affected, flexor digitorum longus and flexor hallucis longus. The necessity of open reduction in case of failed attempt closed reduction, continue to reduction through external maneuvers in practice. So don't struggle with it. Push, put like a pin. I'd like to always to put like a distraction or Dunham pin in the calcaneus and try to maneuver it. And always use a double approach, medial and lateral approach. Open surgical reduction should be done as soon as possible with moving the imposed structure away from the subtalar joint. So this is something you might come for in the middle of the night to get it done. This is not something just to be waiting for the morning. This definitely needs to be done. We'll focus on lateral dislocation as it's more commonly open, difficult to reduce, will mostly require open surgical reduction and need experienced anatomical medial dissection to reach the subtalar joint. The posterior tibial tendon interposition is very commonly attended. As you can see here in this, it just comes in the space between the talus and the calcaneus, and commonly it is intervened there. So definitely you need to go medially and in order to do your dissection and look for the tibialis posterior tendon, because often you see it entrapped between the talus and the calcaneus. Flexor hallucis longus, second more common, and you can easily diagnose by having the big toe flexed like this. And if you relax the IP joint of the big toe, indicates that the tendon is stretched. Augmentation by K-wire or external fixator is usually useful. This indicates stable reduction in contrast of anatomical reduction with augmented fixation. But definitely use of K-wires is very beneficial in these cases. After you doing your reduction, immobilization, then start with weight-bearing protocol. In uncomplicated stage, start weight-bearing about 1 month after the immobilization, while in complicated dislocation, which was one associated with fracture or open dislocation, start weight-bearing, I would say, 1.5 or 2 months after that. The outcome, the literature describes worse prognosis for lateral dislocations compared to the medial. So if you have a lateral subtalar dislocation, expect the worst, and satisfactory outcomes is nearly 30% of lateral dislocation treated conservatively. Even if uncomplicated dislocation, there is always reports of limited range of motion of the subtalar joint with instability. The outcome infected the talus, of course, infection or avascular necrosis of the talus expected to happen in nearly 30% of patients with lateral subtalar dislocation because of the associated injury to the blood supply of the talus. And the foot and ankle, American Orthopedic Foot and Ankle Study has not been validated for the use of this injury, and so far no literature stated scoring system for this injury. So the take-home message: subtalar dislocation is a rare complex injury with drastic complications. If you do improper diagnosis or management, you should recognize the pitfalls, especially the soft tissue interposition, reduction maneuvers, augmentation with KR or XFIX should be always available in your hand to do this. And the literature is subtalar dislocation is a bit not that very common. As you can see, the number of cases not that much, but it definitely needs to be addressed and to be seen. And thank you for your attention. I'm ready for questions.
Thank you very much. And we will finish with Tim Schepers from Amsterdam, a very experienced trauma surgeon. He will be presenting on Schepers dislocations. Thank you, Tim.
Thank you very much, Panos. Thank you very much for the invitation. Love to be here on this 24-hour course. I think it's a great opportunity for everybody to freshen up on their skills. So I hope you can see my presentation and hear me correctly. Excellent. So Schepers dislocations, the previous session already mentioned a bit about Schepers dislocations. Let's show a brief overview and then some cases. So around the Schepers, there's 5 bones, each articulating with 4 to 6 other bones. It's an intricate system like a Swiss clock. If one of the cogwheels doesn't work well, then the rest of the foot doesn't function either. So it's really uncommon, as several of the other speakers already mentioned. Most of the times in a Schepers injury, the cuboid and the navicular bone are injured. So Schepers dislocations is about 15% of all tarsal injuries, and in the literature, 75 to 90% are associated with fractures. I looked at my last 90 to 100 Schepers injuries, and I cannot remember seeing a complete Schepers injury without a fracture. So in my cases, it's almost 100% related to fractures. So the biomechanics, there are 2 columns. The medial column, the talonavicular joint, is really mobile. It's probably one of the most important joints of the foot. And in Schepers, the lateral column is quite rigid. This is in contrast to the Lisfranc joint, where lateral is more mobile. So the TN joint is a ball and socket joint, and the CC joint is a saddle joint, which allow for rotation on uneven surfaces. Well, while adapting to irregular terrain, it absorbs rotation, and the foot is locked on inversion and loose on eversion. It's a little bit more complicated than that, but as we are simple surgeons, this is the message I would like to survey to you. Regarding radiographs, you always need 3 views. I'll show you later why that is. So we need an AP view, we need an oblique view, and we need a lateral view. And of course, a CT scan in these type of injuries is mandatory. The Kuma line, I'm happy to have 2 Greek friends among this panel, so I just put it in there. It's a term for, it allows you to see whether or not the Schepers joint is congruent. You should be able to draw an uninterrupted line in between the talonavicular joint and the calcaneocuboid joint. If not, if there's any overlap, then there might be a problem and you need a CT scan. There are always more than one forces playing, so there's usually one side which is the compression side, the other side is the traction side. can be either the medial or the lateral side that is the compression side, and sometimes it's both. Then you have an axial injury, axial force, which causes both the navicular and the cuboid joint bone to be injured, or the talar head or the anterior process of the talus. This is shown more clearly in the classification that Professor Zwiep came up with, and it just shows you the variation there is on which joint is injured and where to look for the injury and which one should be treated accordingly. As mentioned earlier, Schepers dislocations are rare, especially the ones without fracture, as just mentioned. So isolated dislocations are really rare, and the Schepers injuries with fracture are quite uncommon, as well as indicated by many case reports and only few large series. So what should we aim for? The aim of the treatment is to get a pain-free foot with stable arches, especially, of course, the medial arch. This should be stable, and the foot should be in a plantar position to allow for stable walking. Regarding treatment, we have early definitive treatment. We have a stage treatment, either first with K-wires or external fixation. And of course, there's always the option to refer this patient as soon as possible to a center with more expertise. So I would like to show you a few cases from the last couple of months and a few years ago with some interesting learning points. So this is a male patient, 62 years old. He's healthy. It is a closed injury. He fell with his foot hooked behind the railing of a boat. So he fell on deck of the boat. And these are the initial AP and oblique radiographs that were taken in a hospital nearby. And it might be really difficult to see if there's anything wrong with this picture at all, because as been mentioned before, especially by the American College of Radiology, that you should always have a 3-view study when dealing with complex foot injury. And the reason for this is that all 3 different radiographs add to making the diagnosis. So the AP view is mainly for the medial columns. The oblique view is especially helpful for the lateral columns, and the lateral view is useful for the alignment of the foot. So this is the same patient who came in 9 days later complaining that he still had pain in his foot, and luckily this time they made a lateral view as well, and there you can see that the navicular bone is dislocated plantarwards, and if you look really closely, it's also a bit medialward displacement, and this was now 9 days old. So we got a CT scan, of course, to get a more clear view. And besides a few avulsion fracture of the dorsal capsula of the navicular and the talonavicular joint, there wasn't much injury at all. So we did an open approach of this foot, and we used bridge plating to connect the navicular bone and the cuneiform bones, especially the medial and the intermediate cuneiform, to stabilize the navicular bone. And after that, the TN joint was actually quite stable and didn't need additional fixation anymore. We were wondering if we needed to bridge this joint as well or add a K-wire, but it appeared to be unnecessary. And this is 2.5 years follow-up. He just a couple of months ago, he came by the office and discussed with me whether or not he wanted his implants removed. And because he had very little complaints and these joints don't move that much, we decided on leaving them inside. So the next case is a 45-year-old female patient who likes to go climbing, especially on the climbing wall, but also large mountains. And she came down one of those mountains a little bit quicker than anticipated, and she had this dislocation. So there was only one X-ray, but it was clear that there was an injury. So we made a CT scan, and this is a locked fracture dislocation of the TN joint. There's a navicular fracture and a talar head fracture, and they're in an intimate relationship with each other, but dislocated. And the cuboid joint, the cuboid is fractured as well. It's not really shown clearly here, but it's a little bit more clear here that there's a dislocation. So we did an open reduction, and we discussed with her whether or not this joint was salvageable. So we did an anterior approach for the TN joint, and we did a lateral approach for the calcaneocuboid joint, or the cuboid fracture. And this is peroperatively, the lateral portion of the navicular didn't have any cartilage left at all. So we decided on doing a primary arthrodesis, and we did a temporary fixation of the cuboid joint. And if you look closely, this is the navicular plate, which we didn't have need for on the medial side because we decided on doing a primary fusion. So we used the navicular plate as a bridge plate for the CC joint and the TMT 4 and 5 joint. So this is images peroperatively, where you can see the bridging on the lateral side and a fusion of the TN joint with a plate and cannulated screws on the medial side. And this is the follow-up pictures, and 4 months later we removed the plate on the lateral side, and a couple of weeks ago I removed the plate on the dorsal side of the TN joint. And she just sent me a picture where she climbed quite a big mountain, and she was standing on top cheering that she made it to the top of that mountain with a primary arthrodesis of the TN joint, which I think is quite a good result. So this is a third case, of a young male patient with a dislocation, which was a polytrauma patient with a severe injury of both feet, of a open tibia fracture and a spinal injury. And if you look closely, you can see that there's a distortion in the Lisfranc area, and the talar head is dislocated underneath the navicular bone. And these are the only images we had preoperatively, because these were the soft tissues, and he was in severe pain with a completely swollen foot without a arch left. So the left foot didn't have a arch as seen on the right foot, even though the right foot had a similar injury with a really comminuted calcaneal fracture and a Schepers injury as well. But on the left side, it was clear that there was a compartment syndrome. And there are several ways to release a compartment syndrome. You have the 2 dorsal incisions, 1 medial incision, according to Manoli, but we decided on doing a single incision because we needed to reduce the TN joint. And then we placed a artificial skin in this wound, and we did a temporary K-wire fixation of the TN joint, the Lisfranc joint, and the calcaneus. And a couple of days ago, we did a full thickness graft of the dorsal wound, but his other injuries didn't allow for a definitive treatment yet. So we're probably going to do that even sometime later, or wait and see what happens and do a fusion, triple fusion, probably somewhere in a couple of months. So this is an injury where it was a young athletic patient, might be on a trampoline as well, and there wasn't a real clear injury seen initially. So the CT scan was made about a week later, and it shows that the cuboid joint, the CC joint, and the TMT 4 and 5 are dislocated with a cuboid dislocated plantarwards. And we treated this with a open reduction and K-wire fixation. After reduction of the TMT 4 and 5, the CC joint reduced as well, and we didn't need any more stabilization. And this is 1 year later with maybe some osteoarthritis, but not too much. Probably the last case, 20-year-old male. He was referred, open injuries of his foot and tibia, and they did an open reduction internal fixation of this Schepers injury elsewhere, and they did a screw fixation through all the joints, which I personally do not prefer. And if you look closely, then there is quite a bit of plantarwards dislocation still, with a Mary's angle of about 30 degrees. And this was his dorsal wound of the foot, which was still gapping, opened up because of the plantar dislocation, which was still there. So we revised this injury and went to non-transarticular screws with a Lisfranc screw and a navicular joint screw and a intercuneiform screw. And after that, the alignment was much better, and we were able to primary close, or secondary if you want, close the wound, and it healed quite nicely with a vacuum-assisted closure device for 4 days. And now it's straight again. Last case. Or yeah, do I have 2 minutes? Yes, I think I do.
2 minutes to run.
Excellent. So 52 years old, cardiac problems. He fell through a roof, and he had this dislocation where the talar head went through the bottom of the navicular joint, and Ghisane opened up widely. So this is after manual reduction, and we added a plate on the lateral side of the calcaneus, and what we did is a plantar plate. So we opened up medially, and we inserted like a basket plate underneath the navicular bone to stabilize all the fragments there, and it held quite nicely, and everything healed, and he didn't have his implants removed so far after 1 year. So this might be a different option. So in summary, Schepers dislocations are rare. They seldomly come alone, usually with additional fractures. The goal is a pain-free, stable, and plantigrade foot, and a single stage or a two-stage procedure. Or if you live close by my hospital, you can always refer them to me. Thank you very much.
Thank you.
Thank you.
10-second question. In ankle fracture dislocations, do you recommend immediate reduction before x-rays, or do you wait to get the x-rays?
Yeah, this was answered before, Serafeim.
Yes, I would not wait for the x-rays. If you have a clinically clear situation where you have a severe dislocation, you have to reduce it, because sometimes it takes a little bit more time for the x-rays, and then you have lost the game.
Perfect. Thank you, guys. Thanks, Panos, for amazing.
Thank you, Selene. What a tremendous effort on your behalf.
Well,
great.
I appreciate it. Thanks, guys.
Thank you very much,
Thank you.
everyone. Thank you.
Bye.
Thank you. Bye.